session, and we will be talking and continue our topic from this morning about the radiation protection and radiation safety. And I'm really sorry for this delay, but I'm assure you that it's worth to wait for the session. Once that we have all of the fantastic speakers and the chairperson, but also because the radiation protection is so important. Once it's important for our patients, for us, for the imaging, and also because it's changing so much. So we need to follow it, all of the new developments. And without major delays, I would like to introduce our great chairperson. And if you can just say the one two sentences introducing, please.
Yes, now it's working. Assalamu alaikum, good afternoon everyone. I'm Dr. Lamia Mahmoud. I'm the Regional Advisor for the Prevention of Non-Communicable Diseases in the WHO Eastern Mediterranean Regional Office based here in Cairo. I'm also responsible for the cancer portfolio in WHO. Very, very happy to be with you here today.
Hani Hafiz Lotfi, Professor of Radiology, Assistant Secretary General of Egyptian Society of Radiology and Nuclear Medicine, Head of Maadi Armed Forces College.
Good afternoon all. I'm Dr. Siham Saadani, General Manager of General Directorate of Radiology and Chief of Radiation Protection Officer, as well as Head of the Radiology Committee at the General Authority of Regulation and Registration. Thank you.
So good afternoon. My name is Ola Hornberg, and I'm the head of the Radiation Protection of Patients Unit at the International Atomic Energy Agency. And it's a pleasure for me also to be here. Thank you.
Great, thank you very much. So we know our chairpersons, and we'll have the very excellent speakers after me. But
okay, so I would like to take the opportunity to first say welcome to our first speaker and co-chair, Professor Joanna Kasnia-Brown, who is a senior consultant radiologist at the University of Bristol, UK, and also the current president of the World Federation of Pediatric Imaging. So welcome and thank you.
Great, thank you very much. And I really like to speak to you today about the new recommendations in safe pediatric imaging. And I would like to do it on behalf of the World Federation of Pediatric Imaging, just to show you how important it is in our life. And you see it in every slide or in every presentation when we talked about the pediatric radiation protection and pediatric imaging. And children, we know that the children are not as small adults because they are different. They are not only small in size, but they have a growing and changing body. They have a different body structure. They have a different metabolism and body dynamics, and they are also very active. And we also know that they are more sensitive to the radiation level than the adults. They also have a longer life expectancy, so the cumulative dose will be more important for them. And because they have a small size, and when we want to see the details, we need to increase need for magnification, and we need to have the different settings on our machines, and sometimes we can provide the higher doses to different organs. And also we know that they are more susceptible to the damage. And I show this slide in the morning, which really, every time when I look at this, it just reminds me how important is the radiation that we give to our children and how it's linked into the mortality excess. And you can see it on the left side of the scale and how higher is in the children less or younger than 10 years. And again, when we compare the estimated dose to the days of background radiation, how more of the doses we are going to give our children. So really safe pediatric imaging is about two things: to do the right test at the right time for the patient, and also to do it in the right way. And in radiology, we are very, very lucky because we have a lot of toys to play with. We have a lot of modalities, so we can use the radiography, fluoroscopy, ultrasound, CT imaging, MRI imaging. And we are the people who are responsible which imaging modality we are going to use. And also, we are directing and helping, supporting our clinical colleagues, which examination will be best for the patient. And this is really one of the most common conditions that we image in children. So we do the imaging in trauma, in oncology, congenital conditions, and acute and emergency conditions. And this is about the headaches, acute abdomen, or chest infection when all of the changes are happening. So for example, now we don't really do a CT or a skull X-ray for the headaches because we know how insensitive it is in the patients. We will be very often going straight into the MRI imaging. But now a few words about the trauma imaging. And very often separate to adults, we image children in a different way. When we have the polytrauma, even the not very high impact one in adults, the patients are falling in the traffic accident, very often we will go straight into the CT. And what we do the whole body CTs in adults. So we do the unenhanced CT of the head, then we do the contrast injections, and then we do the whole body scan. But now the question is it really important, and do we need to do it in children? And this is why for children we have completely separate imaging guidelines in pediatric trauma. We know that the majority of pediatric injuries are mainly to the extremities, so we don't need to image the whole body. We have lesser extent to the imaging to the injury to the head and the cervical spine, and that injury pattern is typically into the isolated anatomical areas, so we don't need to go straight into the CT. And also, we need to appreciate the pattern of the injury when we choose the right imaging, and the whole body CT is not always required. So let's look at the cervical spine. It's a relatively radiosensitive region, all of the soft tissue and organ in the neck, and we know that the bone injury is less than 2% of the patients with trauma. So the clinical assessment is really important because it should guide what we are going to do. And if we worry about the adequate plain films, very often the X-rays will be enough for us and we don't need to proceed for CT. But also we know that the pediatric neck injury usually is ligamentous and will require MRI assessment. So X-ray and MRI is our pattern, when in adults we will be going for CT. So when you go for a MRI, we will look at the edema and especially of the subtle fractures. And this is one of our young patients, and you can see the CT on this patient, which really doesn't show any abnormalities within the vertebra, when the MRI on the same day shows a lot of edema and the fractures which they are parallel to the end plates. And it's the same when we are talking into the ligamentous injury or the disc injury, and you can see here in this patient, fractures going in through the intervertebral discs, going into the facet joints, into the ligaments, and into the soft tissue. Of course, we can do CT in this patient, but it will be pointless because we won't see any abnormalities. Another indication with the thorax. Children don't sustain a significant thoracic injury with the blunt trauma because the structure of the chest is different and the ribs. So no thoracic CT is required if the chest X-ray is normal. And even if you see the pulmonary contusion on the chest X-ray, like in this patient, we don't really need to do the CT because what else CT will show you? Just the same as the X-ray. So if the patient is stable, we need to remember the patient needs to be stable and assessed properly. We don't need to do the CT. Children also very rarely have the bone injury and associated life-threatening blood loss from the pelvic injury. So no indication for screening pelvic X-rays as a part of the trauma series in these children. And CT pelvis is only required if the concerns of the injury after clinical examination. What about the oncology? We know that imaging oncology for different reasons. We look at the initial diagnosis, local extension, staging, monitor response to treatment, evaluation of the complication. And really, until a couple of years ago, or a few years ago, our pattern of diagnosis in pediatric radiology, we're doing the ultrasound, especially for chest and abdomen, looking and finding the abnormality. And then we were doing CT for the further evaluation of the lesion and for extent of the disease. But now we are changing CT and MRI. And you can see it here in the same patients, that the lesion within the chest, lesion within the abdomen, it's much, much better delineated on the MRI. We can see more details. We can do the diffusion-weighted images, and you can see it here in the central part, which will show you the active malignant infiltration towards necrosis and the fibrosis. And we also can see very nicely adjacent structures, invasion of the structures and the blood vessels. So MRI, it's much better. What about the distal staging? We know that CT was brilliant before, but look at the new techniques in MRI. You have a comparison here between the CT chest, T2 blade, PD blade, and T1 blade. With the very quick blades algorithm of the scanning, the quality of the lung images is much, much better. And another example here that you can see the bronchiectasis, bronchial wall thickening, and the consolidation. Similar view to the CT. So the old research and the old techniques, we were worried about looking at the metastasis of the small nodule in the lung. But with the new techniques, as a T1 flash and T2 blade, we will have the results of 80 to 90% sensitivity for lesion more than 4 millimeters. If the lesion is less than 4 millimeters, the lesion is indeterminate, and we won't be treating it as a metastasis anyway. What about lymphadenopathy? In the previous, again, old sequences, we have problems to find the lymph nodes less than 8 millimeters. And now, if you put the new sequences as a flash, blade, or Dixon technique, you have 98 and 98% of the sensitivity and the specificity for the lymph nodes more than 6 millimeters. Additionally, here, you can put the diffusion-weighted images and look at the malignant infiltration. Another aspect of the safe imaging in children. Okay. Another example is the referral guidelines. We always follow and work on the referral guidelines together. But this is the example of the new referral guidelines published by the Royal College of Surgeons in England. This happens a few months ago. And we've been put in the situation that they, in their guidelines, recommend that all patients with acute abdomen needs imaging, all patients with acute appendicitis need CT before the surgery, and all children need the CT before the surgery. And this is what the surgeons put into their guidelines, but we were not consulted. So of course that we will do CT, you will see the beautiful appendicitis with the ficolid as is it here. But we all know that we can demonstrate the acute appendicitis very well with the ultrasound, or if you can't see it on the ultrasound, you can do it MRI. So both techniques are without a radiation doses in these children. So do the right test, but do it also in the right way. And this is why it's always very important in the pediatric imaging. And we know in radiography that radiography is still the most common examination that we use in all of the kind of the imaging. And we have a different recommendations how we can perform the radiography, how we can reduce the radiation dose. But one of the new aspects of the radiography, especially abdominal radiography, is gonadal shielding. And we will recommend gonadal shielding for many, many years because this is what we knew and we thought that this was the best way to do it. So the correct placement of the gonadal shielding is very important. It needs to be good size and shape for the patient. But there are a lot of different problems with this. Movement during the procedure, anxiety of the pediatric patient when you put something on the top of them. Also, very often they obscure the underlying anatomy and examine organs, incomplete covering of the organs. There are several articles published showing the different position of the ovaries without the pelvis, and very often we need to repeat the X-ray examination because the quality. And the most important is, by using the shielding, we will increase the dose to the other organs within the body which they are not covered by shielding. So, is gonadal shielding still required? I think that it was questioned a few years ago, but the first recommendations came from American Association of Physicians in Medicine in 2019, who published the position statement on the use of patient gonadal and fetal shielding. Then the British Institute of Radiology followed in 2020, and the European Consensus on Patient Shielding has been published last year. And all of this big organization, after multifocal and multi-center research, concluded that use of the gonadal shielding is not longer recommended in abdominal X-ray. CT scanning. Approximately 10 to 20% is the growth rate per year, and we are doing a lot of millions of CT examination in children, and up to 30% of pediatric scans are multi-phase, and they are performed in children less than 10 years of age. And this is what I show in the morning to our technologists that always follow the best guidance how to perform the abdominal CT imaging. So use definitely the diagnostic reference level, look at the diagnostic quality, and look at the radiation dose, how we can reduce it. And the dual energy CT, it's a new development of the last year. And in the beginning, we were thinking that this will definitely increase the radiation dose. But when you set up the right protocol, we start using it more in abdominal and the chest imaging in children and the young adults. And really, the new recommendations and the new research shows that the dual energy CT can reduce the radiation dose and use of the contrast medium that we use in pediatric radiology. So with the safe imaging, perform only the necessary examination, use the referral guidelines for justification, but the referral guidelines that are accepted by all specialties, accepted by pediatricians, clinicians, by radiologists, not just the one group. When I show you before with the surgical guidelines. Replace the different imaging modalities when possible with the ultrasound and MRI. Use the pediatric specific protocols and reduce number of multi-phase examination. And for us radiologists, and especially pediatric radiologists, it's really important to be visible and to work as a one team and engage with all of the clinical specialties and engage with other societies and the big organization, because in that way we can achieve more and ensure the safe pediatric imaging. Thank you very much for your attention.
Shall I introduce? So thank you.